Now coming to one of the common major gynecological surgery being done vaginally, that is vaginal hysterectomy. Vaginal hysterectomy is a procedure in which the uterus is surgically removed through the vagina. Mostly it is done in perimenopausal or postmenopausal women associated with prolapse, but at times there are certain other indications which we'll be coming to later. So normally ovaries and fallopian tubes are not removed through the vaginal route, but they may be removed during the vaginal hysterectomy, that is bilateral salpingorectomy is done at times. Though it is difficult to do vaginally as compared to the abdominal route. A vaginal approach also may be used if the uterus is not greatly enlarged and without prolapse, and if the reason for the surgery is not related to cancer, that is non-descent vaginal hysterectomy, which has come into vogue during the recent few years. If vaginal hysterectomy is done along with the associated cystocele, enterocele and rectocele repair, then the term of Ward-Mayos operation is given. So mostly vaginal hysterectomy is an ideal operation for postmenopausal women with complete prolapse, as the atrophic uterus does not provide a good anchor for the ligaments of support. The essential part of the operation is approximation of the stems of the ligaments in the midline and the suspension of the vaginal vault to them so that the later on vault prolapse doesn't occur. So what are the indications of vaginal hysterectomy? They include pelvic organ prolapse in most of the cases, but also includes abnormal uterine bleeding, fibroids, certain cervical abnormalities, endometrial hyperplasia, and chronic pelvic pain after excluding other causes of pain. So what are the contraindications for vaginal hysterectomy? If the uterus is very bulky, more than 12 to 14 week size, but nowadays even bigger sizes are being removed vaginally associated with along with the other helpful procedures. Uterus, and second contraindication is the uterus is fixed by abdominal adhesions and inflammatory disease. Abdominal adhesions are likely to be present if the woman has had previous abdominal surgery or cesarean section, especially repeated cesarean section. Some of the other pelvic pathologies in which vaginal hysterectomy is contraindicated include endometriosis and ovarian tumors. In these cases, usually laparotomy is better than the vaginal route. But some of the experts are also able to remove ovaries by the vaginal route if it's not very big. So there are certain advantages of vaginal hysterectomy over total abdominal hysterectomy. They include early resumption of day-to-day activity. Post-operative complications are less in case of vaginal hysterectomy. There is less operative pain and less need for analgesia because there is no scar over the abdomen, so that skin pain over the skin area is all diminished. So less morbidity and mortality, and it can be done effectively in obese patients. But of course, there are certain disadvantages of vaginal hysterectomy. They include skilled surgeon is needed for doing vaginal hysterectomy as compared to the abdominal route. Then exploration of abdominal and pelvic organs cannot be done when we are doing hysterectomy through the vaginal route. And it is difficult to do if there are restricted mobility especially due to adhesions, and difficult with the uterine size of more than 12 weeks. And if there are tubal and ovarian pathology are there, then it is difficult to tackle vaginally. So now we're coming to the procedure. Patient preparation. Pre-operative testing as for major surgery is done, that is ECG. There is basic blood testing, chest x-ray are done, and usually 1 unit of packed cells are reserved. Then also depends upon the status of anemia of the patient. consent and overnight fasting, and some sedative or an anxiolytic is given the previous night. Then the clipping of the pubic hair is done. Enema usually it's not given, but it's optional. So for patients at risk for thrombosis, then thromboembolism prophylaxis is given preoperatively. And prophylactic antibiotic agent should be given as a single dose 30 minutes prior to surgery. Steps, of course, first anesthesia is given, spinal epidural or combined spinal epidural or general anesthesia, but mostly it is regional anesthesia which is given. Position is dorsal lithotomy position and Trendelenburg if required. Then again, before proceeding for the surgery proper, one should do a vaginal examination under anesthesia to know the size of the uterus, downward mobility of the uterus, then any adnexal pathology and all is to be excluded. And so that the final plan for surgery can be determined. So under aseptic precautions, the parts are painted and draped. This is not cauterization, it is catheterization to empty bladder, and the lower edge of the bladder is noted, usually with a bladder sound. So because we should know where the incision is to be given. The cervix is grasped, usually with the Valsalem forceps, and saline with or without epinephrine is given for hemostasis, injected below the vaginal mucosa. This procedure is called as hydrodissection. This hydrodissection is done to minimize the blood loss during dissection. Either the 10 to 15 ml of a diluted saline solution containing vasopressin is given, or lignocaine is given along with the epinephrine. So epinephrine is contraindicated if the patient is hypertensive. So some surgeons, they do not prefer to give these agents for hydrodissection. But some think that this hydrodissection makes the surgery easier. The fluid which goes underneath the vaginal tissue also separates the facial planes and makes dissection easier. So here with this thing, hydrodissection, that is the fluid is being given underneath the vaginal mucosa. So after hydrodissection, a circular incision is given over the cervix below the lower edge of the bladder. That's why we should know where the bladder edge finishes, and the vaginal mucosa is dissected off the cervix all around. Once that dissection is done, the vesicocervical ligament, which is there between the bladder and the cervix, is cut. So once that is cut, if we push the bladder up, then the anteriorly utrovesical fold of peritoneum can be seen, and this thing that is incised. After the bladder is pushed, then when one goes posteriorly and the posterior peritoneum or the pouch of Douglas is opened. If there is a lot of redundant peritoneum is there, that is excised at this stage. That also can be done at the later stage. So thereafter, the first clamp is applied to the uterosacral ligament as close to the uterus as possible, after confirming that the posterior blade is inside the peritoneal cavity. So this is the uterosacral ligament which is being ligated. So that is, first it is clamped, then cut, and then ligated. And this type of suturing is known as the transfixation. And the uterosacral pedicle threads are kept long after identification. Either the uterosacral ligament can be clamped and cut along with the cardinal ligament, or the uterosacral ligament followed by cardinal ligaments can be cut depending upon the size of those ligaments. Once these lateral ligaments are cut, then the uterine vessels are clamped, cut and ligated on both the sides. The next step is clamping of the utero-ovarian ligament and fallopian tube. That is, here the three structures come: a round ligament, ovarian ligament, and the fallopian tube. Sometimes it is difficult to clamp these structures if one goes from below, and at times we have to do this fundal inversion to permit the conal structures to be clamped. So once they are clamped, then they are cut and ligated. So once this step is done on both the sides, then the uterus and cervix is removed. The pedicle is visualized for any bleeding, and if there is any hemostasis is not achieved, further sutures can be taken. Instead of using the sutures, alternative methods of tying pedicles also can be done, like ligature vessel sealing system can be used, which is quite easier, where the bipolar radio frequency generator is used. So, and nowadays there are so many other sealers are available, which makes the surgery easier. So this finishes the vaginal hysterectomy, and usually now we have to tackle with the other prolapses like enterocele, which also comes in the enterocele, rectocele, and cystocele if they are present. So first one should visualize whether the enterocele is present. Enterocele is also part of the middle compartment. So if it is there, then this is repaired after the uterus is removed. The redundant peritoneum of the pouch of Douglas is dissected, and the peritoneal sac is excised, and the neck of the enterocele is ligated. So this enterocele aperture is closed and strengthened by approximating the two uterosacral ligaments. We'll be coming with this part during the next few slides. And this procedure also can be used for the prophylaxis of further wart prolapse. So this is the enterocele repair. Here is the enterocele. If it is not cut, the peritoneum it is cut, then it is seen, and this intestine is pushed inside, and at the neck that's ligature is put, and the redundant peritoneum is excised. So this can be done, cul-de-sac repair can be done by the vaginal route or even by the abdominal route, which we will be coming to later. So once, as we have already seen, that the peritoneum is dissected at its highest point, and the peritoneum is ligated at its highest point, and peritoneum is excised. So after doing the peritoneal thing, then this defect is closed by approximating the uterosacral ligaments in the midline, which is termed as the McCall's Culdoplasty. So how do we do McCall Culdoplasty? Here suture is taken through the vaginal wall from outside from the patient's left side, that is if you are a right-handed surgeon, and then through the left uterosacral ligament. This is continued as a series of bites through the serosa of the anterior rectosigmoid if you go high, or maybe posterior peritoneum, and then through the right uterosacral ligament and brought out through the vaginal vault on the right side. So this also prevents the vaginal vault of prolapse by supporting the vaginal vault. So now this is so when the suture is tied, the uterosacals are brought together and fixed on the vaginal wall. The excess of the vaginal wall is excised. So here we can see, actually there is two type of McCall sutures. One is internal and this one is external. So through the uterosacral ligaments over the serosa and out from the other uterosacral ligament. And if you're coming from outside, then this is the external, and the ones which is like little higher, they are the internal McCall suture. So by doing this, the vault is elevated, and so this prevents further vaginal vault prolapse at a later stage. So when we are doing, especially when you are going high up over here, you should be careful that the ureter is not injured. So once this is done, the vaginal vault is closed and then packed, and catheter is left in situ for about 24 to 48 hours. So Enterocele can be corrected by abdominal route also. So vaginal vault after hysterectomy can be suspended to the uterosacral ligament on either side to prevent enterocele. Other procedures used for enterocele are Halban's procedure and Moskowitz procedure. In Halban's procedure, parallel sutures from up down and up to the pouch of Douglas, and again goes up on the anterior surface. So this picture shows when the uterus is there. If the uterus is not there, the anterior goes sutures over the anterior peritoneum. So these are the parallel sutures which are going on, and then they're tight, and that's how that dead space is obliterated, and further enterocele will not occur. In the Moskowitz suture, which is depicted over here, we usually give circular sutures over here, and it pierces the uterosacral ligaments when we are doing this procedure. So again, especially when we are near the uterosacral ligament, one should be careful that the ureters are not injured. So now coming to the pelvic floor. So that is the anterior compartment and the posterior compartment. So pelvic floor repair, in short, it's known as PFR. It is a corrective operation done for prolapse of the anterior vaginal wall associated with any form of posterior vaginal wall prolapse and relaxed perineum. It should be emphasized that it is not an operation for uterine descent. Uterine descent is a separate thing, and vaginal wall prolapse is a separate entity. So this includes, that is, the PFR includes anterior colporrhaphy and COLPORRHAPHY. It is as the uterine descent is associated with prolapse of the vaginal wall, PFR has to be done along with the operation of the uterine descent. So mostly they are combined with each other. So coming for the operations for the anterior wall compartment. So this is performed to repair the cystocele and at times cystourethrocoele. So anterior colporrhaphy is done when there is midline cystocele or anterior cystocele. In this procedure, traction is given on the cervix to expose the anterior vaginal wall. An inverted T-shaped incision is made on the anterior vaginal wall. Initially, a horizontal incision is given below the bladder margin, as we had given at the same level when we started the vaginal hysterectomy. And through the midpoint of this incision, a vertical incision is given, and which is extended up to the urethral opening. So this becomes an inverted T. So the vaginal walls are reflected on either side to expose the bladder and the vesicovaginal fascia. So the overlying vesicovaginal fascia is tightened and the excess vaginal wall is excised to correct the laxity, and vaginal wall is sutured. So this explains the vertical incision over here. Then it has been separated, and the supporting tissue, vesicovaginal fascia, they are approximated, and here the approximation is complete. A redundant vaginal wall is excised, and then the vagina is sutured. The next diagram has been taken from your book. Again, these we have already dealt with. This is separation, and then the anterior peritoneum or the utrovesical fold of peritoneum is cut open over here. Then the bladder is pushed up. Then the vesicovaginal fascia, they are approximated with each other, and then the redundant vaginal wall is cut over here. And if there are any pending fascia is there, that again is approximated, and then the vaginal wall is sutured again in the inverted T fashion. Coming to the paravaginal repair, it's a method to correct a lateral defect or lateral cystocele. So in the beginning of the lecture, we had seen that cystocele can be the midline defect or the lateral defect when it is away from the that ligament. So here it can be corrected either by the abdominal method or by the vaginal method. Abdominal method involves entering the retropubic space and approximating the detached vagina to the arcus tendinous fascia. It's not going up. Sorry. So this is the abdominal approach which is being given. So this arcus tendinous fascia will be here. This is much clearer. So if there is defect over there, then this is approximated and sutures like this. So then it is already sutured over here, so that we are attaching the vagina to the arcus tendinous fascia, so that the paravaginal space is obliterated and then paravaginal repair is done. This is much clearer. Here there is a defect over here, and these two are approximated, and that is the final picture how it comes. So the same thing can be done through the vaginal route also, though it is slightly difficult through the vaginal route because the visibility is hampered. Now going to the posterior compartment, the surgeries involved are posterior colporrhaphy and COLPORRAPHY. These procedures are done to correct a rectocele and repair a deficient perineum. So the repair of rectocele is done by plicating the rectovaginal fascia, and that's why it termed as posterior colporrhaphy. First, a transverse incision is given along the mucocutaneous junction of the posterior fourchette. Then incision is extended upwards as an inverted T on the posterior vaginal wall up to the upper limit of the rectocele. So here initially actually we have to give a transverse incision over here, extending from one carunculum multiformis to the other, and then this vertical incision is given over here, so then it becomes an inverted T. So once the inverted T incision is given, the vagina is separated from the underlying tissue. So here they are demonstrating the prerectal fascia, and this is the epithelium of the posterior vaginal wall. That is, once the posterior vaginal wall has been separated from the underlying tissue. So after that, the rectovaginal fascia, it is approximated. This thing, lax vagina over the rectocele is excised, and the rectovaginal fascia is repaired after reducing the rectocele. So like we had done in the anterior colporrhaphy. The rectovaginal fascia visible on the surface of the rectum is plicated by the transverse suture, which goes from the left to the right. So multiple sutures, one above the other, is given depending upon the extent of the rectocele. So once we do that, this reconstructs the fascia and supports the rectal wall. So, so this is the final picture after that, and then the vagina is closed in a longitudinal fashion. So then, some people they approximate the levator ani muscle also, but it is said that if you approximate, and especially if you tighten the levator muscle, ani muscle, and then later on dyspareunia can occur. And usually this colporrhaphy is combined with the perineorrhaphy if there is a defect perineal body. So then the posterior compartment defects also can be repaired by a site-specific repair. That site-specific repair means it's not the generalized repair of the rectovaginal fascia. Wherever there is a rent, those areas only are repaired. So that's why the exact nature and the site of the posterior wall defect is identified and then repaired. Of course, the first step is incision of the vagina, and then the separation from the underlying tissue. Then the rectovaginal fascia is visible. So defects in the rectovaginal fascia are identified and they are repaired wherever there is a defect. Not the whole of the rectovaginal fascia is repaired. So usually in the obstetric injuries, when it occurs, there is a transverse defect in the rectovaginal fascia at various levels. And it is better to do rectal examination, then the visibility is better. So those rents are repaired, and then the damaged ends of the fascia retract, and once this thing is repaired, then the damaged ends of the fascia retract upwards and downwards depending upon the site of those defects, and these are brought together by the sutures in the direction in which the defect has occurred, and later on the sutures is covered by the vaginal tissue. So this is the rough picture. This is the vagina. This is the fascia. So if there is a rent over here, that specific rent is repaired and the vagina is closed over there. Whereas in the posterior colporrhaphy, only the rectovaginal septum or fascia is approximated with each other, irrespective of where the rent is there. So perineorrhaphy is a reconstruction of perineal body. This should be done very carefully, as at times if we do overcorrection, this can lead to the narrowing of the introitus and dyspareunia. So in perineorrhaphy procedure, posterior part of the pubovagiнаlis muscle can be identified on both sides. These are approximated by 1 or 2 sutures, and then the retracted ends of the muscle forming the perineal body, that is superficial and deep perineal muscles, which are also involved in the episiotomy if you remember, are approximated by interrupted sutures. Then the vagina in the incision is closed and the skin is sutured. So after doing pelvic floor repair, tight vaginal packing is usually done for 24 hours to prevent any hemorrhage in the vesicovaginal or rectovaginal spaces. Self-retaining catheter in the bladder with continuous drainage for 48 to 72 hours is advised. So if we have given a non-absorbable suture have been used, then these perineal stitches should be removed after 5 to 7 days. But nowadays usually we are using only Vicryl, which is a long-acting absorbable suture. So complications of vaginal hysterectomy with the pelvic floor repair. Since the vaginal hysterectomy is usually done with the pelvic floor repair, so we are dealing it with the combined complications. So it can be either immediate complications or late complications. The immediate complications involves hemorrhage, which can be primary, that is at the time of surgery, and secondary, which occurs later on. Then there can be injury to the adjacent organs like bladder, small bowel, rectum, ureter and urethra. Then there can be complications related to anesthesia as with any surgical procedure. Then thrombosis and pulmonary embolism. So that's why in various indicated, the thromboprophylaxis should be given, and especially if the surgery has been prolonged, then it is more frequent. Then there are chances of infection with the vaginal hysterectomy. They include urinary tract infection and the cuff cellulitis. If the infection is severe, then vaginal vault abscess also can occur, and peritonitis also may be there. Though late complications include dyspareunia, especially if we have removed too much of overzealous correction, too much of vaginal wall has been removed, because the space becomes narrow and the vagina becomes short. So a recurrence of prolapse also can occur, especially if we have not taken proper preventive measures and the vaginal vault has not been secured properly. That's why it's not only the removal of vagina, more than the removal of the uterus. More than the removal of the uterus, it is how we tackle the various supports of the uterus which keep the vault at its place. Thank you.